So this presentation is also meant to be interactive. So there's a fair bit of jargon and science. And if you have any questions, just raise your arm, your hand, and we'll stop. It's for you. It's for you to have an opportunity to ask questions and to learn about myeloma. So I'm going to talk a little bit about the Myeloma Center, what we've achieved so far, a little bit about the work of myeloma, the things that we look for, some of the clinical data that we gathered over the years, and lastly, where we think we're heading in the future. So the Myeloma Institute has been here for 30 years now. So Dr. Barley started this in 1989. And he and his colleagues at that time really led the foundation with the help of many others over the years for a very successful program. And we really have had people from all states, from all around the world. We've performed a large number of stem cell transplants. And the philosophy is that we try to follow everybody here lifelong, so that we don't only have 3 or 5 year follow-up on the patient, but we really try to follow on from what we call from the cradle to the grave. One of the other things that is characteristics of our program that we try to use all available drugs upfront together with stem cell transplantation. So I'm not going to highlight all these things, but in the 30 years that we've been here, there have been many firsts. I think we were the first to introduce 2 transplants in myeloma in 1989. In 1991, we did the very first outpatient transplant. Dr. Barley discovered the first novel drug in myeloma, that is thalidomide. We started to do systematic PET scanning very early on. In the late 90s. We then started developing the gene expression profile. We used this to very stringently define high and low risk multiple myeloma, and also to segment and identify certain molecular subtypes. Using that information, we started to design protocols for high and low risk. Low risk in our approach doesn't mean little treatment. It means a very good outcome with very significant amount of treatment. We've been also developing genomic signatures to predict response. We developed a model to predict the progression from smoldering disease to active myeloma. And we've been very active in sequencing multiple myeloma, particularly under the stewardship of Dr. Morgan and Dr. Walker, and made further discoveries there, which also can lead to more targeted therapy. And by now we've performed over 11,000 stem cell transplants. So this is, in a nutshell, 30-year history. And I think it's something to be proud of. And again, many years, many people over a very long period of time have contributed to all of this. So what is multiple myeloma? Multiple myeloma is a cancer of the plasma cells, and the plasma cells live in the bone. The job of normal plasma cells is to make antibodies. So if the plasma cells go wrong, they will start to make one antibody, one particular type, and that's what we call the myeloma protein. Myeloma is not a cancer of the bone, it's a cancer of the bone marrow, but it can cause bone damage. So this is what myeloma cells look like under a microscope. You can see here the cell nucleus, this is the cytoplasm, and in the light bit are lakes of this one particular type of antibody that myeloma cells make. So what are the things that you need to have to make a diagnosis of multiple myeloma? First of all, you need to have the cancerous plasma cells. which we detect in the bone marrow. Then usually patients make an abnormal protein, this abnormal antibody, one time, which we can detect in blood and urine. And then very often there is bone damage. So the myeloma cells interact with the bone and cause bone destruction. And this is what we refer to as lesions, which we look for on imaging studies. So myeloma is a disease really of the elderly. It's more common in the 6th and 7th decades of life. It's more common in males, more common in African Americans. There are some known causative factors like ionizing radiation and Agent Orange. But for the most part, we currently don't know why an individual patient develops myeloma. Again, here you can see how the incidence goes up with age. We do see people of all ages here. We see people in their 20s, in their 30s. And we even had a young boy aged 19 with multiple myeloma. But again, there is a predominance towards the older age group. So you're all aware of the workup that we do, particularly the first time you come here. We don't do a whole barrage of tests. Essentially, the three things that we always look at are depicted on this slide. We look at your myeloma markers, the blood and urine. We look what's going on in the bone marrow, and we do some form of imaging study, like PET scan, MRI. So those usually are the three critical things that we look at. Turning to the tumor markers in the blood and urine, the myeloma markers. Again, what we call the myeloma protein is a production of a single antibody by cancerous plasma cells, and we call that the myeloma protein, or the M component. Some patients make also what we call free light chains, which is a component of the myeloma protein. I'll show that on the next slide. And then we do 24-hour urine collections to measure the secretion of these proteins in urine. So here you can see what is called an M-spike. This is one type of antibody that the cancerous cells make. So there are different types of antibodies. You've got classes of antibodies. So you can either make an IgG antibody, an IgA, an IgM, or an IgD, and very rarely an IgE. Now the IgG, A, M, or D refers to the heavy chain here of the antibody molecule. There are two light chains, and they're called kappa or lambda. And some patients make extra kappa or lambda, and that's what we measure with the free light chain assay. So we measure the monoclonal protein, the M-spike, and a lot of patients make extra free light chain. Some patients only make free light chain. So these are the two tumor markers we look at. And then we obviously measure them in the urine as well. So this is a test which is called immunofixation. It's an antibody test, and we determine what type of antibody or light chain you're producing. So this patient makes an IgA antibody, that's the heavy chain, and produces also extra light chain, and it's of the lambda variety. And this lambda free light chain gets excreted here in the urine test, in the urine protein electrophoresis. You can see it here. So these are the things that we measure. So we measure the whole myeloma protein, we measure the light chains, and then we measure what's happening in the urine. So those really are the three things that we follow in terms of tumor markers. Okay, these are myeloma cells under the microscope. And on the left, you can see the plasma cells which look more mature, like normal plasma cells. And these plasma cells here look differently. You can see here that their nucleus is open. And this is an area where active gene transcription occurs. The genes are active here. And this usually means that there's more aggressive disease. So already by just looking at the cells in the microscope, you can have some sort of idea whether the disease is more benign or behaving more aggressively. The other thing that we do with the bone marrow is to put it in the test tube and to get it to grow. And that allows us to look at what we call the chromosomes. So here you can see all the chromosomes. You have one from your dad and one from your mother. So this chromosome 1 would have two copies of chromosome 2. This look all normal. Here, this is abnormal. We've got 3 copies of chromosome 3, 3 of 5, 3 of 7, 3 of 11. So this is clearly abnormal. Now this test allows a visual inspection of the chromosomes. So you can look at all the chromosomes. Now the downside of this test is that the myeloma cells must be able to grow in the test tube. And only in 30% of patients you can get informative, what we call metaphase cytogenetics. It means that you can look at the chromosomes under a microscope. So it's a useful test, but it's informative only in 30% of patients. The other test that you hear about is called FISH. And FISH is a test where where you use very specific probes and you decide to look at one particular area in the DNA. For instance, there is a probe for a specific area of chromosome 4, and then there's another probe for chromosome 14. This doesn't project very well, but for instance, the chromosome 4 probe would be red, and the chromosome 14 probe yellow. And if there's material being exchanged between chromosome 4 and 14, these probes localize and they turn up as yellow. Just maybe if you dim the light a little bit, you can see it better. This doesn't project very well. So with the FISH test, you use very specific probes. Here you can see the little red spots here. Here are the green spots, and here they co-localize, which means material between chromosome 4 and 14 has been swapped. So the FISH test, for the FISH test, the bone marrow cells do not need to be grown. So you can do it on everybody. The downside is you look for very specific abnormalities, genetic abnormalities. So you will only find what you look for. So the two are really complementary. We've done gene expression profiling, which was developed or done systematically here since the late 90s, early 2000 in patients. And it builds up a picture of the activity of all the genes in the multiple myeloma cells. And using that, we identified 70 genes which discriminate patients into 2 groups. One has got high-risk myeloma and one standard or low-risk myeloma. And these patients have a very different outcome. So I think this was a very important discovery. You'll hear people talking about low and high-risk myeloma, and there are different definitions being used in the myeloma community. And I'll tell you a little bit about that in the next few slides. The other thing we found that there are different molecular subgroups of multiple myeloma. So here we recognize at least 7 different subgroups. And these have different clinical characteristics, and some respond in a different way to therapy. For instance, in a molecular subgroup that we call the CD2 molecular subgroup, they have a low complete remission rate with excellent outcomes. In other words, this is a disease which does not require the eradication of the last cell. And even if there's some remaining myeloma cells, the patients do very well. In contrast, the subgroup which we call the CD1 subgroup, that has got the highest remission rate, also for low-risk disease, but also the highest relapse rate. So all these different groups have different characteristics. And some of them we think respond better to certain types of drugs, like what we call the MS subgroup there. These are patients which particularly benefit from drugs like Velcade, Carfolus, and Mimlaro, the proteasome inhibitors. So this tells you that myeloma is a fairly complicated disease. And then if you take a subgroup, then there are different percentages of high and low risk patients based on the 70D model. So this immediately makes clear that there's an enormous complexity in multiple myeloma. And with the event of the sequencing, and there are different ways of sequencing and looking at the DNA and RNA, the whole picture becomes much more complicated. And here, the cancers are organized according to the number of mutations. This is pediatric ALL, and when you compare it to a tree, it's got a relatively limited mutational spectrum. Here's myeloma, which sort of falls in the middle, and you can see here that there are a number of different clones there with different mutations. So what we try to do with our approach is to deal with the whole mutation spectrum of the cancer. Turning to imaging, we have different imaging modalities. Maybe you should think a little bit. Yeah. So on the CT scan, you can very clearly see the structure of the bones and bone destruction. On the conventional MRI, which for some reason doesn't project that well, you can see the anatomy really well. You can see the vertebral bodies, the spinal cord, you can see bone lesions, but it really doesn't tell you anything about the activity of the disease. So it tells you that it's there, that there's a lesion there, but then you'll have to compare it with the next MRI, whether it gets bigger or smaller. So this doesn't give you anything about the activity of the disease. The PET scan is based on a sugar dye, and it tells you how active the myeloma cells. Here you can see that most of the marrow is lining up. Then we got something like the whole body MRI, that's the quick 30 minutes MRI. And that's a little bit like a PET scan. So it doesn't give the same anatomical resolution of an MRI, but it does tell you something about the activity of the disease. So all these imaging modalities are really complementary, and they tell you something different about the myeloma disease. So here, for instance, you have a patient, if you're looking here at the wings of the pelvis, so that's the areas that you can feel here, it develops a focal lesion, which gets larger on the MRI, and here's a new one in the femur, in the thigh bone. And all of this you don't see on conventional skeletal X-rays. So in other words, all these imaging techniques are much more sensitive than the old-fashioned, what we call bone surveys. Also, the number of focal lesions, for instance on MRI, does have some bearing on how well you're going to do. If you have more than 7 focal lesions on MRI, your overall outcome is worse than if you have no focal lesions on MRI. However, fortunately, many patients do extremely well despite focal bone disease. And in a number of patients, about 50% of patients to MRI will completely normalize over time. Here's an area where Dr. Zangari is interested in, and you can see here that there's bone destruction here in the pelvis, and here you can actually see a hole in the pelvis. You can see the difference here. And then after treatment, you can see that this is starting to normalize. Here it's starting to heal. Now, the left side is not quite the same as the right, but you can see there's considerable regrowth of bone. Now, we don't quite understand yet why certain patients regrow the bone and others don't. that's an area, as I said, particularly Dr. Zander is interested in. Turning to PET scanning. So PET scanning is a whole body scan. It uses sugar-based dyes, and if the cells are more active, the spots are brighter. So it identifies where the disease grows in lumps and bumps. It can also detect disease outside the bone marrow, and the CT portion allows you to look at what we call the bone destruction. So on the left you see a normal PET scan. The brain takes up a lot of sugar. This is the heart. We excrete the dye by the kidneys, so you can see the kidneys and the bladder. And here you can see lots of hot spots throughout the skeleton. Now, some of you have found that the PET scan is sometimes difficult to get approved by insurance companies. It's now Medicare approved, and it's also recommended by the NCCN guidelines. So I'm hopeful that it will become easier to get a PET scan done in the future. So PET scanning also bears on outcome. The more the lesions you have at outcome at baseline, particularly if you have 3 or more, then you do slightly worse. Also, what we look for in the follow-up PET scan, whether what we call the lights go out. In other words, whether these spots don't light up anymore. Whether the activity of the myeloma cells in these spots has disappeared. So we like to see that before the transplant, if we do 1 or 2 cycles of induction chemotherapy, that there are no longer any hotspots on PET scan. And if the PET scan has normalized and there's no there are no abnormal hotspots, patients fare better. Now, what about this quick MRI, the whole body diffusion weighted images MRI? For a PET scan, you need to be on a diet, and you don't need to do this for this whole body MRI. What this whole body MRI measures is the movement of water. And you can imagine if an area is packed with cells, that the water doesn't move very well, and that shows up as a spot on this whole body diffusion weighted images MRI. If there are few cells, then there is less restricted movement of water, and you don't see a spot. Again, the anatomy of the PET scan is better, and the diffusion weighted images MRI, the anatomical resolution is not that good. It's also not very good for detecting disease growing outside the bone marrow. So you mainly look for things in the bones. Now we found with this diffusion weighted images MRI that particularly large focal lesions have bearing an outcome. So if you have 3 or more large focal lesions, you fare a little bit worse. So, and we call a large focal lesion larger than 5 centimeters square per perpendicular diameter. So here you can see patients with large focal lesions. So in other words, what that means is that it's not only the number of lesions which is important, but it's in fact the size. So numerous small focal lesions are probably not that important, but if you have 3 or 4 big ones, that is probably more important. And the reason for that is that there are more mutations in these big lesions. So they have a tendency to be more resistant to drug therapy. So all of this gives us information about what type of disease the patient has, and it helps us to tailor therapy. So how do we approach therapy? I think a very important question in terms of giving patients is to decide how fit they are. This is not only determined by age, but also by general physical condition, organ function like heart function, kidney function, lung function, and also how well the normal marrow functions. Some patients have had drug therapy and the normal marrow is damaged and doesn't put out as many cells. We'd like to see what kind of therapy they've had, how they responded, and the last therapy was if they had any side effects of treatment, they can tolerate certain drugs. And then the third thing that we already talked about in terms of the genetics and imaging data, we want to get an idea about the aggressiveness of the disease. And with all this imaging and genetic data, but I'm really trying to tell you that everybody more or less has their little unique myeloma. Try to build up a picture of everybody's myeloma and look for the things that you need to monitor and pay particular attention to. What we don't like is for patients to get what we call sequencing, although it's appropriate for elderly patients who don't tolerate transplants. If you give one or two drugs, then wait until the patient relapses, and then go to another set of one or two drugs and wait until the patient relapses. You run through all your drugs, and you wind up with resistant disease, and every second response or remission is shorter. So what we are quite big on, but sometimes lacks in the plan is an overall plan. What is the strategic approach to this particular patient's myeloma? What is the plan here? What is the goal? What are you going to do? Are you going to aim to try and cure the patient, control the disease? We look at the aggressiveness of the disease, physical fitness, cryotherapy, and then monitoring of the whole implementation of the therapy plan is really important. And you need to be flexible and adjust it if necessary. And there is a lot of emphasis nowadays on what we call minimal residual disease negativity. That's about our flow cytometry test at the marrow, no detectable disease, and also negativity by one of our functional imaging tests, which we call the PET scan and the whole body diffusion images MRI. So it's very important to have a plan and know where you're going. So in the total therapy approach, we try to give induction chemotherapy to bring the disease under control. Then there are one or two transplants, and then any remaining therapy is eradicated with what we call consolidation, and then maintenance. Most of this you will do Little Rock, and the maintenance, our maintenance is 3 years, and that's obviously done at home. So when you, here this is in comparison with an iceberg. Here is the disease at the beginning. After induction, and perhaps transplant, there's a remaining disease. It's no longer easily detectable, perhaps only by flow cytometry in the marrow. And the idea is to eradicate all this low-level residual disease with as goal to get patients cured. So what does total therapy mean, and where does it come from? So in the 1970s and 80s, St. Jude's Research Hospital, which is famous for developing therapy for pediatric acute leukemia, developed an approach which is called the total therapy approach. And they used induction, consolidation, and maintenance chemotherapy. And now, using that approach, over 90% of patients with pediatric leukemia are being cured. So, Dr. Barnett initially used a similar approach, but introduced transplant. Because transplant is very good at killing multiple myeloma. And he found that one transplant gave a 20% complete remission rate, and two gave a 40% complete remission rate. And with children, childhood acute leukemia, it was found that if there was a 40% complete remission rate, some of these patients were cured. So that's where the simple idea of doing two transplants came from. And what we've then been doing over the years is incorporating novel drugs into this approach of induction, transplant, consolidation, and maintenance. The first one was thalidomide. Then in total therapy 2 and total therapy 3, we used Velcade, and we separated the patients out into high and low risk, and we had specific protocols for that. Total therapy 4, and total therapy 5 we incorporated carfilzomib, and now in total therapy 7 for high risk disease, we incorporate both carfilzomib and an antibody called daratumumab. So what this approach is aiming to do is incorporate all novel drugs up front. We try to address, by doing that, by exposing the cancer to multiple drugs, to overcome drug resistance, and to deal with a very complicated mutational spectrum. We want to optimize the response of the disease using this approach and prevent what we call further mutations, clonal evolution, and disease escape. And if we can, we think that in some patients we can cure this disease. So this is our success over the many years, the success of total therapy protocols. And these are the low-risk patients. This is our total therapy 3 protocol, which we started in 2003, the yellow line. And you can see that there is a plateau appearing on the curve here, so patients stop relapsing. So the cure rate here is probably in the order of 50% in this protocol. So we're doing very well with the low-risk patients. Obviously, there's room for further improvement. What the challenge is are the high-risk patients. And this is a very difficult patient group. And I think we've been struggling with this over the years. And in fact, any major myeloma center finds that these patients are challenging because up until now their overall outcome has not been good. And it's almost like a very aggressive lymphoma or leukemia. It's sort of a binary outcome. You're either going to be cured of the disease or you will eventually die of it. So it's not like you can't turn this into a chronic disease with which you coexist. Obviously, there are new treatment modalities. We're trying to incorporate the Darzalex drug in our total therapy 7 protocol to see whether we can improve outcome. So these look like fairly standard approaches, a sort of one-size-fits-all approach, but we really want to get away from it. So what we really want to do is have a more personalized approach, and that's where the myeloma therapy needs to go into the future. The good thing in myeloma is that we've got many novel drugs available nowadays. I'm old enough to remember that we didn't have thalidomide. We had old-fashioned chemotherapy, and we had transplant and high-dose dexamethasone. And all of you don't like dexamethasone. It used to be given 40 milligrams for 4 days. 4 days on, 4 days off. Like day 1, 4, 9, 12, 17, 21. That's a heck of a lot of dexamethasone. And people took it because there were not that many options. Fortunately, we've got now a whole slew of new drugs, which are all useful in certain situations. So, and there are more drugs to follow. We've got a drug called venetoclax. There's another drug called selinexor. They're probably slated to get next FDA approval. And they're exciting developments with genetically engineered T cells. So there's an increasing toolkit to use in the future. So what do we do in our total therapy 7 protocol? With chemotherapy up front, that is the induction, and we incorporate the Darzalex drug. Then they get 1 transplant, the first transplant, and then afterwards we give consolidation with immunotherapy with the Darzalex drug, and then we add some easier chemotherapy to it, the Caprolis drug. They get a second transplant, then they get again immunotherapy with the daratumumab, and then they do maintenance with daratumumab and carfilzomib, and we alternate that in cycles with daratumumab and the revenue drug. So one of the ideas is we hope that the DARZALEX can overcome the high-risk disease, and at the same time that we get rid of some of the cycles of more intensive chemotherapy. So what we'd like to hope is that one, we get less toxic therapy, and hopefully we get better responses. So that's what the Total Therapy 7 protocol is aiming to do. And I think we enrolled around 30 patients right now, and we'll all find out whether it works. Also, with the advent of sequencing and other innovations, we are able to see and develop more precise drug that targets specifically mutations. And there are a number of targets here for which there are currently drugs into clinical trial. And some of these will make it into the clinic. So what we call precision medicine will be available for a number of patients. Then there's also an enormous interest in immunological therapies. This is, for instance, an antibody which is developed by GlaxoSmithKline. It's an antibody which targets the myeloma cells and it carries a cytotoxic drug. So it very specifically delivers the cytotoxic drug to the myeloma cell. The technical name is an antibody-drug conjugate. So it's almost like a silver bullet carrying chemotherapy to the myeloma cells. Then there are also what we call so-called bispecific antibodies. What these antibodies do, they grab with one arm an immune cell and activate it. And with the other arm of the antibody, they grab the myeloma cells and bring them together. So you bring together an activated immune cell and a myeloma cell. And the idea is that these cells, the immune cells, kill the myeloma cell. Then there are the CAR T cells, which are cells genetically engineered to take the patient's own cell. We put in an antibody fragment which recognizes the myeloma cell, and then these cells are being activated. So there are a number of these CAR T cells in clinical trial, and in some cases they're very good responses. We don't quite know yet how durable these responses are. But then again, we're mostly working with the very first generation of these CAR T cells. So I think in future, more innovations can be expected which will make this therapy more efficacious. And then there are different antibodies. I'm just singling out this DARZALEX antibody again, which through multiple mechanisms kills myeloma cells. There are other antibodies in development as well. So what the future will bring is that we can hopefully leverage a number of approaches. We have all this information about sequencing. We've got sophisticated imaging. We can integrate that with clinical data, with information about the patient's immune system and the environment in which the tumor lives, and develop models to try and predict what the best therapy is for a patient. And then hopefully some of these new therapies or the incorporation of these novel therapies will deliver better outcome. So that's where the future is going to be. And I think this is a lot of information. some of it must have been very difficult to digest. But please feel free to ask me any questions.
Before we get questions, does anybody have any parking we need to validate? I got yours up front. Anybody? Okay. Mia, can you help me, Mia? On that end.
We're going to be given a copy of what you presented so we can digest a little bit more.
Sure, absolutely. Yeah.
We can probably get we can pass around you got an email?
Yes.
Yeah, that's probably we can email it to you, I'm sure.
This is being broadcast on Facebook Live, and you can go back and watch it later when we post
I
on
try to stay
Facebook
off
Live.
Facebook.
And we're trying to put it on our website as well.
It's really hard to hear on the Facebook Live broadcasting, because I have family back home trying to watch it, and I can't really hear it, so.
I got another question too. My wife's being considered as a patient, one of these 50 patients, and there's 36 pages that I haven't completely read it all yet. But I know we have Medicare, we have Blue Cross Blue Shield supplement, and we have some Aflac insurance, which has nothing, that's covered, it comes to us, not to the cancer center, but I know, I've heard that Medicare only covers one transplant. And where would we go if you had to have a second, if you sign up for this? I understand it costs about $120,000 for the second transplant.
Okay, so all the protocols are written bearing in mind that some patients can't have two transplants, whether they're Medicare or whether their insurance doesn't approve two transplants. So the ability not to have two transplants does not mean that you can't go on this protocol. So the schema is then adjusted for only having one transplant.
Yeah, we can do it with just one. Yeah. And Medicare will pay for more than one transplant, they just don't pay for tandem transplants, there's a difference. So they will pay for one planned transplant, but if you ever need a second transplant, say there's a relapse or something like that, they will pay for a second transplant.
If she's high risk, then that's subject to relapse.
So that would be an option, if she needed it in the future though, so.
And to keep it Medicare on those tandem transplants, should also be submitted one at a time.
Yeah,
So you can't say we're gonna do two or we're planning to do two. You do one predetermination at a time, so it's totally different.
Well, I understand too, it requires a lot of travel from Alabama. Yeah, we had to fly in here Wednesday night at 12 o'clock on a med flight. And that was 16,500 up here in
I think in general terms, for everybody who comes to Little Rock, a fair amount of the therapy, of the upfront therapy is delivered here. So I think all of you are probably aware and already committing time to being there. What we call the maintenance, so we call also some extended therapy is not at home, obviously. Because you can't spend your entire life in Little Rock.
the other thing to say is this facility here is made for that. We do have low-income housing that is right around here. We have short-term housing. A lot of people just do it in inpatient because for finances, a lot of times we have to do all the treatment in the hospital because if you have difficulty paying for like a short-term apartment or something, there's always option to do it as an inpatient where that is less financial burden on the patient.
Well,
it is the travel commitment, of course.
So my real question is, I know she's going to have to travel back for even under the regular plan.
Yeah.
If she signs up for this plan, this trial, well, how much more is she going to have to travel? Because right now she can only get in a wheelchair. She may have a broken hip, two broken ribs, and a broken collarbone, and she's pretty sick.
So in some patients who come here quite sick and with problems or pain or bone issues, I think sometimes you need to do one step at a time. We can't always exactly map out how treatment is going to be. So like I said, you need to be flexible, adjust therapy, not only based on response, but also based on how the patient is doing and what their physical fitness is.
Well, that's true, but I'm trying to look at, because I move over here, you know, if I'm going to be coming every month, that's quite a distance out of I'm over here.
Some patients choose to rent an apartment for 6 months.
Well, we have an apartment now,
Yeah.
but I got to kind of, I'll sell my house and move over here. I want to do everything I can for my wife for survival.
Patients do better when they start treatment sometimes because they're so sick when they get diagnosed. Treatment sometimes will make you feel better. And of course, heal the lesions in the bones and take care of the bone problems first.
But you can't do you can't do hip surgery while you're in treatment, not long. See, that's my problem. But anyway, I think I got a general idea.
I have a question. You spoke about the fish test. When would you do something like that? You don't do it on every patient, correct?
We do it on everybody who comes here for the first time to characterize their disease. And very often we do it at relapse to see what has changed.
Okay.
So diagnosis and relapses, but not on every single donor.
Dr. Bailey, if you've gone through the whole system, you've been in remission for, say, 3 years, and you have a relapse, what's the difference between going through the regular poison system, I like to call it, or going through immunotherapy?
So there are different types of immunotherapy. The way you're going to treat somebody depends on how they relapse. Some patients just have very slow reaccumulation of their disease, and it all doesn't grow very aggressively, and it can be very easily managed. Some patients, at some stage, particularly when they relapse more than 3 years out, they do really well with the third transplant, and you can get long-term survival. We also look at the way patients relapses, what their particular subtype is, to what drugs they respond well. So sometimes drug combinations can be used, typically three drugs, and there are a number of different combinations. The Darzalex is a very good monoclonal antibody, is a form of immunological therapy. And we very often use that as part of the treatment. Then if you're talking about the CAR T cells have more toxicities associated with it.
Toxicity?
Yes. There's something called cytokine release syndrome that can make people sick.
I don't think anything is toxic enough.
No, this is not a reason for not going for CAR T cell therapy, but at this moment in time, you really reserve it for patients with more advanced disease, for more difficult disease. So somebody with an easy early relapse, you wouldn't send for CAR T cell therapy at this moment in time.
Somebody had myeloma, not know it, and this, my wife used to exercise all the time and walk. This just happened 6 months ago.
So,
How do you, I notice a lot of people in the park have it, and they're able to attend this meeting, but my wife can't, so she's at high risk. But I'm just wondering, how long ago did she have developed this disease?
So in most patients, or virtually all patients, the disease is preceded by a pre-myeloma stage, which we call MGUS, or smoldering disease, okay? And sometimes that very gradually develops into frank myeloma over time. Most of these patients will present more of what we call low-risk disease or standard risk disease. They will have real myeloma. Then there are other patients in which mutations occur and the tempo of the disease speed up. So they have developed much faster growing myeloma, and their time from going perhaps from smoldering to frank myeloma is much shorter. And they usually have a lot of clinical manifestations of the disease. So the answer is she could have been developing this for years. And in other patients, the period to developing frank disease is much shorter.
She had breast cancer in 1990, but I've been told it had nothing to do with her developing breast cancer.
Now, in general terms, radiation can pre-expose to myeloma, so people with radiation therapy for other tumors. But otherwise, usually other cancers don't predispose by itself. Their therapy can, particularly radiation therapy.
I've noticed that a large portion of the people I've met that have myeloma had broken bones before they ever knew they had it.
Yes.
Right.
That happens a lot.
Broken bones before he knew.
Well, she broke her
he
right
had myeloma.
collar, she broke 2 ribs, and now she has probably a broken hip. This has all happened within 2 or 3 weeks, 3 weeks maybe.
It's hard for a lot of general practitioners to identify, and, they just.
Well, her family doctor told her old age. She's only 70.
Well, quite often the disease gets especially,
We are.
so the disease gets especially in younger patients.
Yeah.
That because they don't think about myeloma when you're 40 or 50. So the mindset is the patient of 70, 80 have myeloma, but not 30, 40, 50. Fortunately, with increased healthcare, many more patients get diagnosed when incidental tests are done, blood tests or x-rays, before they have frank manifestations or broken bones. Because that's a pretty bad complication.
But it doesn't always surface in bones. No.
That's true.
It also surfaces in an organ failure.
Kidneys, yeah.
Yes.
So should it show up on a regular x-ray? Because like when it started with my mom like 3 months ago, her general doctor just took an x-ray, wouldn't do an MRI, and just put it off his back pain. Should something have, would it have developed within that 3 months since the x-ray? Or does it not usually
But
show?
let me, in your particular scenario, an MRI or PET scan would have shown disease at that time.
Yeah, they would.
But in general terms, plain X-rays are not very sensitive to detect myelomatous bone disease. You need to have at least 50% bone destruction before you see something on a plain X-ray. An MRI or PET scanning or these more sophisticated imaging techniques are much more sensitive in picking up bone disease.
If you were diagnosed with low risk to begin with, you went into remission, then you do follow-up tests, all of a sudden it shows that you're no longer in remission. Would you be reevaluated again as far as low risk or high risk?
Yeah, I think that's critically important because you want to know what you're dealing with. You may give, you adjust your therapy based on that as well. So some patients have low risk myeloma and then either during or after therapy at some stage they can relapse with high risk disease. So yes, that's a very important assessment to make.
Can you start at high risk and become low risk?
Okay, we consider that if you have been diagnosed with high risk, that you harbor more aggressive disease. So, although on a subsequent bone marrow, if we do a repeat gene array, it may come out at low risk. We are always worried that there are residual aggressive disease-resistant cells, that these are present. So, in other words, once high risk, always high risk. At least from the therapy point of view.
That picture you showed of the hip growing back the bone,
Yeah.
how much time had passed?
This doesn't happen overnight. It
Yeah.
usually takes 2-3 years.
Okay.
And it doesn't happen in all patients, for sure. And we don't quite understand why there's so much repair in some patients and virtually no repair in others. So that's one of the other things that we need to understand. So in going forward, we're going to do this meeting in more regulatory, more regularly. So the format can be different, and all of you can have also requests. So if you find that a certain topic needs to be addressed, if you would just like to have a question and answer session, I think we've done that in the past. Some patients like to hear what opportunities social work has to offer. So we can address a variety of topics. We also tend to rotate the physicians who come, so that you get to know all our doctors. And usually when you ask an opinion from 3 different myeloma doctors, you'll get 3 slightly different answers. And those of you who have been to more than one center will know that.
As long as they're all good answers.
What about consultation between the doctors and physicians after you had tests on the individual and the test shows such and such? Do they present this to the doctors as far as therapy goes?
You mean in the department?
Yes.
Yeah, every new patient gets discussed together with a radiologist and pathologist. So we discuss clinical findings, laboratory findings, the bone marrow, imaging studies, and then we make a plan. And it's an opportunity for everybody to speak up, and also the people to say, well, I don't disagree, I don't agree what you're doing, you should consider doing something different.
What about existing patients?
Pardon?
What about existing patients?
It also applies to existing patients. We bring to this particular meeting also patients with problems who are difficult to manage in terms of their disease or have unusual complications. Obviously, we don't discuss everybody. If you're doing fine and there's no problems, then there's no need for discussion. But we very frequently discuss existing patients. All right.
There's a list I put mine.
Okay.
You got this, your pen?
Yeah, I think it's gonna be in the box.
So how'd y'all like this myeloma, Meet the Myeloma Center? Is it good for you? How'd y'all like the music?
I'd like to thank Robert Langen, one of our pharmaceutical representatives.
Jay, how long are you after transplant?
Excuse me?
When was your transplant?
2016.
There you go, 2016.
I'm doing fine. I'm doing real good, feel good, cancer free. And since you all have me over the coals here, I want to thank Dr. Rhee and Kristen and Diane. And I shouldn't have started calling names because it's a whole lot of other people. But everybody at this place are awesome. They care, and you are, and whoever you are or have that you know are in the best hands ever with these people. They have worked wonders, they care, and it shows. Thank you so much.
You know, it's so funny because when Jay was having his transplant, he was actually out on the sun porch on F7, and he was playing there. One of his sons, one of his other musician sons was with him. He's really an inspiration to all of us too, and that's why we wanted to kind of share them with y'all tonight to give you some, you know, inspiration and see what we're doing here.
I'm not trying to take her back. If I can have one word in conjunction with what she said. I did like a little mini concert in the sunroom, and one of my other sons came from Atlanta to play backup for me, and I was playing there, and I had my IV pole here with my chemo running through my jugular vein, and you know, I got hung up in the cord while I'm trying to play and all this stuff. But the point that I want to make is, when I got finished, a lady stood up, and you never know what you do, what it means to someone else. And a lady stood up and said, "Can I have a word?" I said, "Sure." She said, "You know, people come all the time to talk to us, and they're healthy, and they're doing good, and they tell us we can make it, and sure, it's easy to say when you're not going through it. But when I walked in here, and saw that chemo going through you, just like me, and you're still praising and playing and acting like it's nothing going on, she said, it's a big difference. And I'm so glad I came because it's an example for me. So you never know what effects you have on people when you show them that it can be done and that they too can go. And a lot of it's right here. And my last thing, and I know I'm not the guest speaker. I was in the break room one night, and I was warming my wife. I was fixing my wife some spaghetti. A lady came in and said, "Oh," she said, "who's the patient? Who you're with? Who are you here with?" I said, "I'm the patient." And she said, "Do you mean you're up cooking for your wife and you're the patient?" I said, "Yes." And she told me and gave me her room number. Her husband was going through some moments. She said, "Would you please come to my room and talk to my husband?" And while I was here, I got a chance to visit a whole lot of rooms and uplift a lot of people. So to God be glory.
He brought some with him and it's just him.
And he did 6 cycles in the hospital.
Absolutely.
Everyone.
Absolutely awesome.
We need him on we need him on the 7th floor tonight.
He was there for 6 months.
The other thing to say, if you go to our Facebook page, we have a little commercial for TV about a patient with a particularly bad PET scan.
Yeah.
And it can show you, even if you have a very bad PET scan, how you can overcome this and do really well.
Dr. Frits, I got lost the other night. They dropped me off the clinic. I wound up in the psychiatric ward.
Oh,
I was in trouble.
All right. Well, thank you, Sonia, for having me for organizing it. And Linda.